longer, have been conceptualized for longer, and global health is so to speak, a newer field. And so to highlight some of the unique features of global health, in this table comparing it, he wrote that global health transcends national boundaries, requires global cooperation, promotes health equity among nations, and is highly interdisciplinary and multidisciplinary. And before I move on and talk about our community, I think there's probably no time better than now, or more relevant than now for most of us in our careers in regards to addressing global health. I think over the past year and some change, we've all seen, the effects of global health and health inequity, both locally and worldwide. When it came to access to care for different populations, people from different demographics, from different socioeconomic backgrounds, how people were affected by COVID. And then, when the vaccinations were rolled out, similarly, which people were getting the vaccines, and then how was the acceptance rate different between different populations. And this very much affected us, obviously, locally as well. So I would argue that global health is equally important to be practiced globally as well as locally among all of us. So now I want to spend some time talking about our community right here in Brooklyn. So as you guys all know, I work at Maimonides, and Brooklyn is actually quite a diverse, Brooklyn and Queens here are quite diverse boroughs, ethnically and culturally. So this map of Brooklyn and Queens is showing the second most common languages spoken in different households across different neighborhoods in Brooklyn and Queens. And as you can see in red is Spanish. So Spanish predominates as the second most common language. But then you also have pockets of other languages such as Russian, Yiddish, Chinese, whether it's Mandarin, Cantonese, Fujianese, etc., French Creole. So there's clearly a lot of ethnic and cultural diversity among the population that we serve here in Brooklyn. But not only that, but there's also a variability among the background, the socioeconomic background that our patients are coming from. So in the next couple of slides, I'm going to show you, again, maps of Brooklyn. And just to orient you with these maps, the darker shaded areas, the darker shaded purple means that there's a higher percentage, and the larger the circle, the higher the rate. And so here you're seeing that there's quite a lot of variability in regards to people living below poverty line across Brooklyn. And then if you look at unemployment rates, again, similarly, you're seeing that there's variability in pockets of neighborhoods within Brooklyn where people are unemployed at quite high rates. And what's striking is that this map is similar in distribution to the map I just showed you. And in terms of where our hospitals are located, you can see that the darker shaded purple is in the neighborhoods where we serve. So, whether it's Sunset Park or Flatbush or Crown Heights, you see that a big portion of our patient population is coming from these neighborhoods. And then how does that translate to the care that these patients are receiving? Well, again, this map, as you can see in regards to the darker shaded purple, is quite similar to the last two maps I showed you. And this map is looking at the total Medicaid beneficiaries within each neighborhood. And so, again, you can see the distribution of people across these neighborhoods is the same for the people that are unemployed and are living in poverty. And then this last map is showing the total uninsured population within neighborhoods. And again, you can kind of see pockets of neighborhoods where people are living and don't have insurance, so clearly don't have the best or any access to healthcare. So again, this is all to say that global health is really quite relevant for each and every single one of us. Every time that you're treating a patient, you're really practicing global health right here in Brooklyn. So I'm going to switch gears now a little bit and talk about global neurology. So this is a quote from an article by Gretchen Berbeck, who is one of the pioneers of global neurology. And she wrote this article on academic careers in global neurology in 2014. And in this quote, she wrote, "Global neurology, meaning sustained and dedicated work related to neurologic research, education, advocacy, and/or clinical care in the global health arena, is an academic field in its infancy." And I put this quote up here to really highlight that indeed global neurology is an emerging subspecialty. This article was published less than a decade ago, and much of the kind of formal work that has been done in global neurology has been done over the past decade or so. Well, why is this relevant? So even though the field of global or the subfield of global neurology is in its infancy, neurological disease, as we all know, certainly is not. And in fact, globally, neurological disease is the number one cause of disability globally. And it's the second leading cause of mortality. So certainly, while maybe this field is in its infancy, there's a lot of work to be done globally. So again, in the next few slides, as promised, you're going to see a whole bunch of maps. I'm going to, again, start out kind of locally on a national scale, and then zoom out and look at what's going on globally in terms of the burden of neurological disease. And all these maps are from studies done from Global Burden of Disease. And these studies have been done since 1990, and there's been multiple renditions. And to orient you here, the darker red means that there's a higher rate of neurological disease, and the bluer means that there's lower rates of neurologic disease. And each map of the United States here represents a different neurological disorder. And so, rather than going through each and every single map, I really put this up here to highlight that even within our own country, there's quite a significant amount of variability in terms of the burden of neurological disease across different neurological conditions. And some of this you can kind of explain in the top right corner. You see the burden of neurological disease in terms of MS, and you see that, as we know, there's the states in the northern latitude tend to be affected more so. And then in the top left, you see that the Southeast is more affected, known as the stroke belt. But then across other neurological disease, there's high variability as well. And then these are just more maps of the US, and top left is migraine. So you can see that migraine is quite prevalent in the US. And then top right and bottom left are meningitis and encephalitis. And we have lower cases of that here in the US as compared to the rest of the world. So then looking at the rest of the world and looking at the disability from neurological disease, you can see that the US and in general, North America and parts of South America and Western Europe are overall doing well, whereas, a bunch of countries from Africa and some countries in South America and in Southeast Asia, et cetera, are more affected by disability from neurologic disease. And in fact, more than 3/4 of the global burden of neurological disease is coming from these countries. And these countries are also low and lower middle income countries. So this is just showing you a map of disability from neurologic disease, and this is showing you death from neurologic disorders. And as you can see, the distribution here is quite similar. So this is another way at looking at the data. So this is looking at kind of the most burdensome neurological disorders globally that cause disability on the left and death on the right. So the top 3 causes globally of disability from neurologic disease are stroke, Alzheimer's disease and other dementias, and migraine. And the top 3 causes of death from neurological disorder are stroke, once again, Alzheimer's disease and other dementias, and meningitis. This is another way of looking at which disorders globally are most burdensome, but this is looking at it by different regions. And the goal of, the point that this graph is trying to make is that the top 3 most burdensome neurologic disease that cause disability across the board are stroke, migraine, and Alzheimer's disease and other dementias. So you can see that's kind of the most red across all those boxes across the 21 GPT regions. But as you go further down, there is some variability. So, while some parts of the world are more affected by meningitis, other parts of the world have other neurologic diseases that are more burdensome, such as spinal cord injury and traumatic brain injury. So all of these maps that I just showed clearly show that there's a significant global burden of neurologic disease. So how do we combat it? What do we have to fight this neurologic disease globally? And before I show you the next couple of slides, There was an atlas that the WHO came out with in regards to some of the resources that are available or perhaps not available to combat neurologic disease. Before I show you the atlas, I just wanted to review the 6 WHO regions globally, because I think that this is relevant when we look at the data. So one of the 6 regions is American, and as you can see, all of the Americas, both North and South America, are grouped together. Another region is European, and again, you can see that Eastern Europe, Western Europe, all of Russia, all of that is grouped into a European region. Most of Africa is grouped into an African region, Northern Africa, and some of the Middle East is grouped into the Eastern Mediterranean region. And then you have the Southeast Asian region and Western Pacific region. So it's an interesting way that they kind of group some of these higher income countries and low and lower middle income countries together. So then looking at the graph, to preface the caveat with this data is that the way that it was collected is countries were surveyed globally, but not all countries responded. So as you can see here, globally, 114 countries responded. And in some cases, more countries responded per region than in other regions. And then in some cases, some of these countries just don't have the data. And in those instances, there was a focal point person for a country who guesstimated, the data based on their geographical borders. So as you can imagine, this data may not be the most accurate, but just to kind of give you a representation, this graph is looking at the number of adult neurologists per 100,000 people across different regions. And as you can see, Europe, the countries in Europe have the most adult neurologists available. So there's about 6.5 adult neurologists per 100,000 people. But as you can see in other regions across the world, adult neurologists are really lacking. And globally, there's less than half a neurologist per every 100,000 people. So this is, again, looking at similar data, but not just adult neurologists. You see the same numbers on the left for adult neurologists across different regions, but you also see data for neurosurgeons and child neurologists. How available are those specialists? And if we think that there's not enough adult neurologists, and there aren't globally, there's certainly not enough neurosurgeons, not enough child neurologists. So on the bottom right of the 93 countries that responded, there is a median of 0.05 child neurologists per 100,000 population. And then this is further information in regards to the distribution of the adult neurologists. So where are they located? Where do we congregate? Do we work in capital cities? Do we work in urban areas? Do we work in rural areas? And so in green here is the percent of countries with a neurologist in the capital city. In purple is the percent of countries with a neurologist in rural areas. And in blue is the percent of countries with a neurologist in other urban areas. So as you can see, across the board, across the 6 different WHO regions, there's a high percentage of neurologists in capital cities. So most countries, nearly all countries that responded, have a neurologist in the capital city, but that's certainly not the case for rural areas. And globally, about 1/5 of the countries have a neurologist in rural areas. And this is the case here in the United States as well. We certainly are lacking neurologists in rural areas. So we know we're low in terms of the task force, in terms of the manpower to combat neurological disease. But not only that, when we do have neurologists or neurological workforce that's present, do we have the tools? So do we have medicines? Do we have available diagnostic tests on a global scale? And so this is the WHO model list of essential medicines. So this is a list that the WHO has been publishing for decades, every other year. And this list spans medicines across different specialties in medicine. And it's really meant to be used as a guide, especially for countries in low and lower middle income regions. And this list provides a list of medications that are efficacious and that should be cost effective. And a lot of these countries do use this as a guide to kind of help them purchase medications and decide which medications to have on formulary. And the list has actually grown quite a lot in regards to the available infectious disease medications and medications available for neoplasms. But it really hasn't grown all that much in regards to the available medications to fight neurologic disease. And so the top half is showing you the medications that are on the list for neurologic disorders across different neurologic disorders. So medications such as aspirin, such as simvastatin, Plavix, pyridostigmine for myasthenia gravis, those are on the list. But then on the bottom half, there's a whole number of medications that are not on the list, that have not been approved or have not been submitted to be approved by the list. And just to zoom in and look at some of these medications, some of them are really medications that some of us use on a daily basis. So gabapentin, sumatriptan, a whole number of antiepileptics, including Keppra, lamotrigine, et cetera. So those medications didn't make it onto the list. So I will pause here and review everything I've talked about. So what have we learned so far? So again, to redefine global health and repeat what we all kind of said earlier, it's an interdisciplinary field that transcends national boundaries and requires global cooperation to achieve health equity. And we know that inequities exist in healthcare, both here in Brooklyn on a national scale and globally. We also know that there is variability in regards to the global burden of neurologic disease. We know that some areas in our country and some areas globally are affected more so than others. And we also know that we're lacking in resources to fight it. So what can we do about this? How do we move forward? Well, increased research, clinical care, increased education and policies to address these inequities. We need to collaborate, again, both on a local scale, within institutions in New York City, but also globally. We also need to continue to be involved locally in our community. And then what I'm personally interested in is increasing awareness and education and really training kind of the next class of neurologists to be interested, intrigued, and be participatory in global neurology. So with that in mind, I want to take some time to tell you all about my experience in global neurology during my training. So I spent some time in Pietermaritzburg, which is in KwaZulu-Natal, one of the provinces in South Africa. It's located about an hour away from Durban. And I won't go into the complicated social history of South Africa, but needless to say, it has shaped the healthcare system there as well. So there's a public sector and there's a private sector, and the overwhelming majority of the population uses the public sector, which in terms of resources is certainly quite different and lacking as compared to the private sector. So I split my time between two hospitals. I was initially based at Edendale Hospital. Both these hospitals are public hospitals. And Edendale Hospital is a community hospital, and it has primary care doctors such as general medicine, OBGYN, pediatrics. There was an emergency medicine department and surgery. There's no specialists, so there are no cardiologists, no nephrologists, no neurologists. And in order to get specialists on board, the doctors in this hospital had to place a consult via telephone. And in certain select cases, some of the patients actually would get transferred to a tertiary hospital, which I'll tell you about in a second, and receive further care there. But this was certainly quite difficult to achieve. In terms of the resources in the hospital, there was an X-ray machine. There was an ultrasound that was very difficult to come by. And there was actually a CAT scanner. It wasn't functioning most of the time, but it actually was working while I was there. I spent the latter half of my time at Grace Hospital, which is the tertiary hospital in Pietermaritzburg. And this hospital does have a specialist. So it actually had a neurology department, and it had a very small neurology training program. So during my time there, I cataloged the cases, or I tried to catalog as many cases as I could that I saw at both hospitals. And interestingly, in regards to the distribution of neurologic disease, it was quite similar to that seen in that part of the world. So I saw a lot of seizures, I saw a lot of strokes, both ischemic and hemorrhagic. I saw a decent amount of peripheral neuropathy, NOS, that I couldn't, because of the lack of resources, couldn't really figure out what was going on there. And I saw a decent amount of headaches. I did not include consults for altered mental status and generalized weakness that were due to general medical conditions, such as sepsis or hypokalemia. But I thought it was a relief to see that these consults are actually quite universal. So I now want to present a case to you that I saw during my time there. This was a 63-year-old woman with history of pulmonary tuberculosis, which was treated. She had HIV with a CD4 count in the 200s and viral load of 56. And she came in with 3 months of gradually worsening leg weakness and sensory loss, and the left side was more affected than the right. She also had diffuse lower back pain. I was told that she had urinary retention. By the time that I got there, she already had a Foley in place, and she denied any bowel issues, and she had no cranial nerve or arm involvement. Her exam was notable for bilateral leg flaccid paralysis. She had decreased sensation to light touch, pinprick, vibration, and proprioception, again on the left more than the right. She had a questionable sensory level in the mid-thoracic region, and she had absent reflexes in the legs. And she had decreased rectal tone. During her time there, she got basic workup. So she got some serum labs, including a CBC, a CMP. She did get a chest x-ray, and that showed no active pulmonary disease. And during her time and my time there, she was awaiting a CT spine. And I actually left before she left the hospital, but I was told that ultimately her disposition would be home. And so while I think neurologically this case is quite fascinating and it has a broad differential diagnosis and can be discussed quite extensively, I actually put it up here to highlight some of the common themes in global health. So to start out, she is a 63-year-old woman. So when I'm consulted and see a patient in their 60s, I think of them as relatively young, but that's not necessarily the case in the region where I was. So the average life expectancy for a woman in that region is in their 60s. And so right away, right off the bat, as this patient presented to the hospital, the medical staff there already had to triage her and group her into a category, based on some of her basic demographics. Is this woman and is her disease salvageable or not? And unfortunately, we saw this actually happen throughout the world, in some high-income countries as well during the pandemic, where unfortunately, because of lack of resources, doctors had to triage and figure out, which patients are quote unquote salvageable and which ones are not. She also had a history of tuberculosis and HIV. And while these diseases, these infectious diseases are on the downtrend globally, they certainly are more prevalent in some of the low and lower middle income countries than they are in high income countries. And so these patients have medical comorbidities that kind of affect the rest of their potential medical problems, such as neurological disease, and further predisposes them to this. I also mentioned that she had a questionable sensory level. Well, what does that mean? There's either a sensory level or there's not. The reason that I said that it was questionable is I had a very difficult time eliciting both history and exam, and that's because she didn't speak English. So this patient spoke Zulu, and in fact, the majority of the population that comes to this hospital speaks Zulu and does not speak English. Well, this is a problem because the doctors in the hospital, the majority of them don't speak Zulu, they speak English. Some of the nurses speak Zulu, and so as you can imagine, there's no formal interpreting services there. So you have Zulu-speaking nurses who are coming in and out. They're quite busy taking care of scores of other patients, but they will come in and out and intermittently help translate. There's family that occasionally comes by, but there's limited visiting hours. And finally, there are patients that are nice enough that are adjacent. There's rows and rows of beds. There's no separate rooms, and so occasionally there would be patients that were in adjacent beds that would be nice enough to translate as well. But needless to say, I had a very difficult time eliciting a history and an exam. And as you can imagine, this leads to less than ideal patient care. I also mentioned that she was awaiting CT spine the whole time that she and I were there. And again, even though the CAT scanner was functional, it was quite difficult to get a patient a CAT scanner, a CAT scan. And again, the doctors really had to triage and figure out, which patients could be helped and which ones could not, which ones were more emergent, which ones were not. And so again, in regards to resource utilization, it was quite difficult to get everyone the resources that you really needed for them to treat them. And finally, I mentioned that her ultimate disposition would be home. So, I would expect, having heard about this patient, I would expect this patient to go to subacute rehab or acute rehab, to receive extensive physical therapy. Unfortunately, a lot of these patients weren't able to receive those kind of services. And indeed, this patient would ultimately have to go home and be taken care of by her family, which, as you can imagine, is less than ideal. So to summarize some of the challenges that I faced, and these challenges are quite common: language and cultural barrier, resource limitations, and resource utilization, socioeconomic factors. Where's the patient coming from? What's their background? What's their financial status? What's their educational level? And then systems-wide factors. So what kind of systems are in place for patients that have active neurologic disease and then patients that are recovering from neurologic disease? So are there dedicated stroke centers? Are there epilepsy monitoring units? Are there rehabilitation centers? And certainly that's lacking. And I would argue that while this is certainly prevalent for many of us in our global health international experiences, this is also, some of these challenges at the very least are quite common right here in our community in Brooklyn as well. So that was my experience in global neurology. What's other trainees' experience like? So this is actually a study that came out just this year, and this was surveying either neurology trainees or former neurology trainees who had completed a global health experience, an international experience, and it was asking for feedback. And so reassuringly, 100% of them recommended this experience to others, which is great news. And then they commented on some common themes that emerge as someone completes a global health experience. So generally, trainees feel that their examination skills and their clinical acumen improves after a global health rotation. They're more thoughtful and careful in regards to resource utilization. What tests must be ordered? Will this really change my management? They also become better at understanding healthcare systems, both globally and locally. And I would argue, most importantly, when these trainees come back, they feel more committed, more ready to work with underserved populations. And again, this applies both globally and locally. So shifting gears to our trainees, I sent out a very brief short survey to our neurology trainees about half a year ago. I just asked them a few simple questions in regards to their interests in global health, and only about 2/3 responded. So not the best response rate, but of the ones that responded, reassuringly, the overwhelming majority, or 94%, said they were interested in global health. And the overwhelming majority also said they were interested in global health curriculum. And then 15 residents said that they would be interested in completing an international elective. So this is all great news. I also found this very interesting and fascinating. So our residents are quite diverse, just like our population in Brooklyn. And I asked the residents, what other languages besides English do you speak? And keep in mind that only 2/3 of the residents responded. But I would say this is quite an extensive list. And this is very much relevant because, speaking another language is certainly very helpful in patient care, as I showed you a few slides earlier, both in our diverse communities in Brooklyn, but also as one completes an international elective. So what goes into a global neurology elective? Well, this is from a paper that showed a general timeline in regards to how to prepare for an international elective. And it really starts off early in training, and the resident really needs to think about things like mentorship, where they want to go, what they want their experience to be like. Do they want to be research-based or clinical-based? Do they want to focus on education? Think about funding. And then, through the years, ultimately typically in their senior years, a trainee completes an international elective and then comes back and holds a debriefing with a home institution. So I think this is a good general timeline, but I would argue that for a more comprehensive, rich experience, there are certain aspects that are missing from this timeline. So one of those is a global health curriculum. And this can be really quite variable. This can be didactics, this can be conferences, seminars, independent reading, modules, and there's quite a number of modules that are available nowadays in regards to global health curricula, but something to supplement their international elective, and in fact, something to prepare them for their international elective. In addition to this, while the resident is abroad or even locally completing their global health rotation, it's important to keep in touch with the home institution. And that can mean participating in morning report and noon conferences. Ideally, there's participation both from the home and host institution and bi-directional learning. And finally, as I've alluded time and again, really ideally the residents should also be involved in their own community, and there's really few places as good as Brooklyn to be involved in global health locally. And this can really happen throughout their training. It doesn't have to happen after the global health rotation. It can happen before or throughout residency or after the international elective. So in conclusion, I'm very excited to be working on some projects, both kind of at Downstate for the neurology residency and with some folks at Maimonides. So some of the things that I'll be working on in the next year or so is developing global health curricula, global and community health curricula for our residents in the next academic year, and really focusing on things like cultural competency and community health. I think it's also important for us to address the patients, the vulnerable patients in our community, whether that's with free clinic or going out to the community and providing education regarding neurological diseases. And then, as I mentioned, I'm actually working with a couple of folks at Maimonides. So we have an interdepartmental collaboration between our department, neurology, OBGYN, pediatrics, and emergency medicine. And we've created what we've called the Global Health Institute. And it's really to form a centralized place for trainees within different residencies at Maimonides and be kind of a one-stop shop for all things global health related, whether that's involvement in the community, projects in the community, providing, a centralized place for international electives and creating a more streamlined process for that, and really developing a forum for our trainees to engage in global health conversations. So I would like to thank all of you for listening. I would also like to thank Dr. Karen Thacker. She is in charge of the Global Neurology program at Columbia, and she's really been quite instrumental both during my training and assisting me and helping to organize my international elective. And also, since I've been at Maimonides, she's really been quite helpful in figuring out and planning how to go about creating a global neurology program here. And then the department, the neurology department at Grace Hospital pictured here, who were very kind enough to share their learning experiences with me during my time there. So thank you very much, and I'm happy to answer any questions.
Thank you, Dr. Chernyak.
I have a question, Dr. Lee. This is Devraj. I'm one of the child neurology chiefs. The question is that how it's changing this global health. Now we have all this virtual walls. So is it like more feasible? Like, is there now resources that people can use that and like help out the?
I think if I heard your question correctly, the question was, how feasible is it to continue practicing global health now that many things are virtual? Is that correct?
Right. And there is any new opportunities for people to help out that?
Yeah. So that's a great question. And I would say that, obviously, while in some ways we're somewhat more limited now in regards to, at least currently providing experience with an international elective. Certainly, we can't do that this very minute, but I'm hopeful that in the future, of course, we can resume. But I would say that in other ways, it's actually made collaborating and working on some of these projects easier. So, even just getting together and talking about creating Global Health Institute has been significantly easier for myself and all the faculty at Maimonides, just by way that this has all been virtual. Actually, we haven't met in person yet, and we've held weekly meetings over the past half a year. But we do have a lot of exciting events and curricula that are coming up. And then, in regards to communicating internationally, I would say that it has also been made easier, even I remember there was a speaker at Grand Rounds a couple of months ago now, and I was interested in pursuing, perhaps an international elective site down the line. And it was just so easy to contact this person and, hold a video conference with them. So I would say in a lot of ways, actually, being virtual has made things easier. And then, the concept of teleneurology obviously is more developed here, just given the resources, but that's also something that people are thinking about on a global scale.
Thank you so much.
Yes, can you hear me?
Yes.
Dr. Anziska, I'm from South Africa and came here in my early 20s. Edendale even then was well known throughout the country. Before 1975, really, all one had were invasive tests like angiograms, pneumoencephalograms, and myelograms. And I'm wondering why, in view of the lack of a functional CAT scan, never mind an MRI, why people didn't do myelograms in patients with spinal cord problems. You can use an ordinary X-ray machine. You can train a general radiologist to do it, or anybody can inject the dye and pictures are taken, and it's quite accurate. So in places which lack resources, such as MRIs, never mind CAT scans, I think one might want to revert to effective, but perhaps more primitive pre-1975 tests.
Yes, I agree with you completely. And, that case in particular was quite upsetting for me. Even a lumbar puncture wasn't done, which I felt was very necessary, but that's a whole different conversation. But yes, you're right. And, using ultrasound, they did have an ultrasound machine. I was told it was actually very difficult to come by. But, using an ultrasound machine for things like optic nerve sheet diameter can really give quite a lot of information. So yes, I agree with you completely.
So maybe we should train our residents and fellows who go to underdeveloped countries to use the old techniques, certainly myelograms. I mean, I understand angiograms are a problem, but myelography was done routinely. It's fairly easy to interpret with a bit of training, and one should reintroduce these things into, places which don't have MRIs. Or the alternative is to have an arrangement with one of the private hospitals to do MRIs, which are quite plentiful in certain parts of South Africa.
Yeah, absolutely. Agreed. Yes. And again, training in ultrasound, I think, would also go a long way, doing, for example, if an ultrasound is available, doing transcranial Dopplers, would be very useful in regards to diagnosis as well.
Thank you.
I have a question, Dr. Chernyak. I was wondering if the global health curriculum, paradoxically should also include, we're talking about rotations in developing countries or underdeveloped countries, but maybe it also should include rotations in some, Western European countries, certain Asian countries, or Canada, where they have arguably a superior, healthcare system with better access to healthcare, so that we can learn, how to achieve that here as well.
Yes, I agree with you. I think in addition to, like you said, residents going to low and lower middle income countries, and, in general, I think residents should be able to go, not even necessarily globally, but even locally, I think there's a lot to be learned as well. I think, one aspect of this, and this is something that some programs are doing, is an international exchange program. And again, as I emphasized, while the residents completing international elective, really kind of having an inter-institutional conference at the very least, to really have kind of both parties here and the host institution be involved and have bidirectional learning. So, this is certainly a two-way street.
Hi, Liz, Stephanie. Just want to say thank you for the talk. I did an elective as a resident in Haiti. Part of the reason was that I had a friend in Haiti, but it was a very good experience. And yeah, I think it's a great thing for residents to do, even though, in these other countries that, the healthcare is not the same as here. It is just like a completely different way of practicing, because they don't have anything that we have. And even getting a CT scan was like a huge deal. So the clinical exam was very important, and the people were so grateful and also just so resilient. I mean, what they went through, they would just carry their family members like through the street, to get them to the hospital. It really made an impression. So I think having that opportunity for residents would be like a really great thing.
Yeah, and Dr. Rabakis actually brought up a very good point. I know that there's at least a couple of faculty in our department that have either done, some kind of international elective or have been involved in global health in some shape or form previously or currently are. And I think it would actually really be great. And I will survey and ask all of you down the line, but, to know who is involved and interested.
Yeah, I do have a contact in Haiti in case anybody wants to go there.
Great.
Okay, I guess if there are no more questions or comments, I would like to thank again Dr. Chernyak for this great lecture today. And I would like to thank everyone also for joining us, and wish everyone a great weekend. Thank you again.
Thank you.